They are also doing live, and they say they have a all India, pan India presence with 2 lakh doctors. So it's a good thing. It's a hybrid meeting. It's a working day. We had some good lectures from the morning, and the evening we'll have valedictory function where I would like, if you can find time around 6:30 to 7 p.m. to join again.
I have time. I have got 2 more meetings, and in one of the meetings you are also invited, mind it. So if you don't have the link, then I'll resend it.
Okay. So what we can do, we can start your presentation. Let me tell Dr. M.K. Das, Mrinal Kanti Das is from Calcutta. He is a very important cardiologist for the Cardiology Society of India. He is the past, not immediate past, but past president of the CSI, Cardiology Society of India. He has an illustrious career, and he has been working actively for the upliftment or improvement in the functioning of Cardiological Society of India, sitting in the headquarters in Calcutta. He's a good friend, and he's a good speaker. He has got mostly interest in clinical cardiology and also interventional cardiology. And he's invited all over the world. He has done some tremendous work in affiliating CSI with other international societies all over the world. So I welcome him as a good friend that he has been able to find time for talking about heart failure. So may I invite Dr. S.N. Pathak and Dr. Amit Munjal to be on the stage for chairing the session. Heart failure is a very important topic, and we all know that numbers of heart failure is increasing day by day as the survival of acute MI is going up, and these patients are landing up with a low ejection fraction. There are 2 types of heart failure. One is with preserved ejection fraction, another is the low ejection fraction. So he will be talking about covering all the aspects. After that, there will be talk by Dr. R.D. Yadav on the device treatment, and then we'll have some pacemaker session. So thank you very much. Dr. Das, please go ahead. If you are hearing me well, I would like you to start the topic. Dr. S.N. Pathak from Apollo Hospital and Dr. Amit Munjal from Hisar. Both are cardiologists in clinical and interventional.
Okay, thank you, Dr. Vivek Gupta. Am I audible?
Yeah, audible. And let me tell you that he's the president of Asian Heart Society 2022-24. It's a very important landmark in his career. And international governors of ACC, American College of Cardiology, Asian representative of the Assembly of International Governor of American College of Cardiology, and of course he's a past president. And of course he's an ace cardiologist and very good social person. That's more important. You have to be a good human being before you become a whatever cardiology and whatever you achieve. Good human being goes with till your death, while your positions, they finish after some time. So he's a very good human being also.
Thank you, Dr. Vivek Gupta, for your good introduction, and really, I possibly don't deserve all those things. But however, I have been given the topic of heart failure. Are my slides visible?
Yeah, perfectly all right. Slides are visible, you are visible, and you are very well audible.
Now, as you know, that heart failure is a syndrome of symptoms and signs. And as per the universal definition, there should be structural deformity in the heart, along with the rise in the BNP or natriuretic peptides. Now, these combinations actually give rise to the diagnosis of heart failure, and I'm going to talk on the update on management of this heart failure. It's of course a global health problem, as Dr. Vivek Gupta has said, but the burden of heart failure in India is gradually increasing because of the fact that the AMI are surviving more and more, interventions are being done more and more, the longevity of the Indians have increased. So with all these, actually, the burden of heart failure in India is a really alarming situation right now. Very interestingly, the heart failure in India actually occurs 10 years younger as compared to the Western counterparts. And also, it affects the lower socioeconomic group in India because of the more rehospitalizations, because of the economic factor. And similarly, the post-admission mortality is also formidable in India as compared to the Western counterpart. The 1-year mortality as well as the 5-year mortality are very, very high. But what is very important that we should know the concept of heart failure. As you know that it has been recently covered as a continuum, the pivot of which actually revolves around the ejection fraction. And as you also know that the ejection fraction can be classified into many types. Out of these, three types are very, very important. One is the heart failure with reduced ejection fraction, when the ejection fraction is less than 40%, and preserved ejection fraction when it is more than 50%. And in between, it is the mid-range ejection fraction or mildly reduced ejection fraction, where it is the 40 to 50, 49% is the left ventricular ejection fraction. And there could be interchangeability between all these three because of the either deterioration or recovery, as you have seen in this slide. And there could be also combination of the various manifestations or various cohorts of the patients which can be attributed to reduced ejection fraction more, as in younger age groups, CAD, diabetes, etc. On the other hand, the preserved ejection fraction with older age female sex and various associated diseases. And in between is the heart failure with mid-range ejection fraction, which can happen with both the groups of the cohorts of reduced ejection fraction and preserved ejection fraction. And almost 50% cases are attributable to the reduced ejection fraction, and rest 50% to the combination of preserved as well as the mid-range or mildly reduced ejection fraction. And out of this, 1/3 is the mid-range, and 2/3 of 50% is preserved ejection fraction. Now, why we talk about the ejection fraction, especially measured by the echocardiography, there could be other modalities which can give the indication that the continuum could be much more synesthetic. And this could be ascertained by the MRI or by the myocardial strain assessment, where even with the normal ejection fraction, there could be lower ejection fraction. And as I have already told that the raised in this natriuretic peptide level, along with the structural abnormality in the form of mid-range or reduced or preserved ejection fraction, can give rise to the various manifestations and various complications. Now, there could be different risk scoring of heart failure, which is very, very important for knowing the management. And QOC for heart failure hospitalization or death is a new one, which has been published in 2022, and based on various risk factors, ejection fractions, end systolic volume, RV systolic pressure, CKD, etc. And as the number of risk factors increase, as in the QOC risk score ranging from -3 to 15, it can be more having the effect on the mortality. Same way, in the preserved ejection fraction, as well as the mid-range ejection fraction, there could be other risk factors which can attribute to the mortality and morbidity of the patient. Now, the event rates and death rates for heart failure also are different, especially with the reduced ejection fraction. It is much more as compared to the preserved ejection fraction and mid-range ejection fraction, and the cumulative rate of events are also more, and the all-cause mortality are also more with the reduced ejection fraction as compared to mid-range ejection fraction and preserved ejection fraction. But the history of recent hospitalizations for heart failure provides a means to identify a high-risk patient population in future trials with heart failure with preserved ejection fraction. Now, the conceptual basis of treatment of heart failure actually started with the concept of definitely the ejection fraction, and various trials ranging from the heart failure ISDN trial to the DELIVER trial, which has been published in 2022. All these based on various positive trials, and they have attributed various drugs, out of which 4 important drugs are very, very important. One is the beta blocker, second is the ACE, then ARB, ARNI, as well as MRA, third is the SGLT2 inhibitors, and fourth is the MRA. Apart from this, there are other drugs like ferric carboxymaltose, ivabradine also, which can influence the morbidity and mortality. But out of these four are called the foundational therapies for heart failure, like RAS inhibitor, SG2, LT2 inhibitor, beta blockers, MRA antagonists. Now, for heart failure with reduced ejection fraction, all the foundational drugs are having the class 1 recommendation. And as you know that recently, all the four drugs have been attributed to improve the mortality and morbidity when you start the drugs almost in succession within 4 weeks of the starting the drugs, as compared to the conventional therapy where sequential up titrating the dose is done. But here, all the drugs like BB, then SGLT2 inhibitors, ARNI, MRA are completed within 4 weeks. Now, the conceptual basis of treatment for heart failure with preserved ejection fraction, definitely all the drugs mentioned were tried, and out of them, all the trials have shown the neutral result. And the SGLT2 inhibitors actually showed the paradigm shift in the management of both the MREF and PEF, because of the fact that they cause natriuresis, improve cardiac biogenetics, inhibition of cardiac sodium hydrogen exchange, reduction in interstitial edema, reduction in preload, and improved kidney function. And thereby, the SGLT2 inhibitor actually has shown a very, very important result in terms of the mortality and morbidity reduction. It started with the soloist WHF trial where the sotagliflozin was better than the placebo. Same way with the empagliflozin, where both the recurrent hospitalization and death rates were reduced. But what was importantly observed with the empagliflozin, that when the ejection fraction was more than 60, it did not show much a better result as compared to the placebo. On the other hand, when we pulled the analysis of DAPA heart failure and DELIVER trial, which has been published in 2022, there has been significant improvement in all the groups of ejection fraction, whether it is reduced ejection fraction or mid-range ejection fraction or the preserved ejection fraction. And also it showed better results in the CKD group, even with the more than 60% ejection fraction, there was improvement with the dapagliflozin. And that's why it has been said that SGLT2 inhibitors works in the whole spectrum of ejection fraction. And that, based on that, the GDMT 2022 regarded all the drugs as a class 2A or 2B indication for heart failure with preserved or mid-range ejection fraction. And as you know that the diuretics are already earmarked as the class 1 indication. Having said all this, there are futuristic thoughts on the molecular targets of the heart failure management. I'm not going into the detail of it, but riesivguat is coming in a big way. Partial adenosine A1 agonist, then elampipretide is another drug. Iron therapy is another important agent which has shown important results, which has been already published. Now, this is another futuristic concept, phenomapping, with the concept of cluster. Different risk factor groups have been attributed, and here with the CKD had the highest risk category cluster, and there are low risk cluster, and all this can be manifested can be managed differently with the different groups of agents. Now, additional therapy when GDMT is optimized could be in the form of surgical revascularization when heart failure is there with less than 35% ejection fraction and suitable coronary anatomy. When there is severe secondary MR, the GDM, and after optimization of GDMT, an intervention with secondary for secondary MR can be done by transcatheter edge to edge mitral valve repair in the form of mitral clip. And also, with the history of heart failure hospitalization recurrently, you can apply the wireless monitoring for pulmonary pressure monitoring, and thereby you can reduce the event rates as well as improve the mortality. Artificial intelligence is coming in a very, very big way. This is the cornerstone for precision medicine, and you can get the continuous feedback based on the biomarkers, clinical variables. Distinct phenotypes can be described, and you can change the trials and change the mechanisms of the trial schedule, and also improve upon the mortality and mortality. So, having said all this, let us give some take-home message. Several data from RCTs shape our understanding of mechanism and therapy for heart failure, and the left ventricular ejection fraction will continue to play an important role in heart failure management. Widely available LVEF will continue like this, and SGLT2 inhibitors are demonstrated to be effective across all the spectrum of ejection fraction. Foundational therapy may change over a period of time because of the newer drugs like vericiguat and other drugs that are being tried in the molecular fronts will definitely change the various paradigm of heart failure management, and thereby the better understanding of genetic, molecular, and mechanistic causes of cardiovascular disease will definitely enhance more targeted treatment and more benefit. Thank you very much for patient hearing.
Great talk, sir. As usual, heart failure is always the challenging for all the cardiologists to treat. Disconnect, okay, sir. Can you hear me, sir?
Yes, I can hear you.
So, to further have some discussion, Dr. R.M. Chabra, he's a senior physician in Delhi. We'll be talking to you for a few minutes. And can you come on the stage? You can, or you take the mic.
Dr. Das, a patient comes to you with the heart failure, ejection fraction 36%, and it is a new patient. With the decomposition, with the diuretics, you will start the ARNI. What is the role of the beta blocker? Or it is a non-diabetic patient. Between the ARNI, you will start the ARNI, and beta blocker and SGLT2, which drug you will start with the diuretics?
Yeah, after the stabilization with the fluid therapy, that is the dehydration therapy, both in terms of the amount of fluid being restricted in intake, as well as the diuretic therapy, you will be stabilizing the patient a little bit, and you can start, as the trials have shown, with the ARNI straight away as the first line of drug. Earlier, we used to take the ACE and ARB. Nowadays, we start with the ARNI straight away. Now, after some more days of stabilization with the heart failure, then you can take up the SGLT2 inhibitor along with that. And so these two might be taken up for 1 to 2 weeks. And later on, you can add on the other drugs like the MRA, as well as the ivabradine, and all these drugs can be added further. And within 4 weeks, you will complete the foundational therapeutic measures. And along with that, if you want, you can add some more drugs as per the requirement or as per the definitive diagnosis of the cause of heart failure.
What about the bradine or the beta blocker? Which will you prefer?
It's a very good question indeed. We'll first add the beta blocker, because that has been shown to be very, very effective in the management of the heart failure. There is no doubt about that. And that's why this beta blocker in heart failure with the reduced ejection fraction has been attributed as a class 1 recommended drug. Now, if the heart rate is still above 70 per rate, that is the indication. If the heart failure is, this heart rate is more than 70, then you can add, not substitute, you can add the ivabradine to that so that the heart rate falls or comes to around 70. And along with that, I must tell you that only in some contraindicated cases of beta blocker, as in bronchospasm or acute asthmatic episode, then possibly you may not add the beta blocker, or you may switch off the beta blocker and straight away go to the ivabradine, even without considering the heart rate mechanism.
Thank you.
Yeah, okay. Any other question? Dr. Pathak, would you like to say something?
So, in any patient, we first categorize the patients, whether the patient is of heart failure with mid-range ejection fraction or preserved ejection fraction, or heart failure with reduced ejection fraction. Depend upon that, we generally prescribe the drugs. If the patient have a heart failure with reduced ejection fraction and a patient have a chronic heart failure, then the first drug that gives the mortality benefit to the patient is the ARNI, number one. Number two, but for the symptomatic benefit, we have to start the diuretics, because the ARNI also have a diuretic actions, but not as much as required by the patients. Number two, beta blocker is the drug that can be started only when the patient is decongested and dry. Otherwise, heart failure may precipitate it.
Absolutely, absolutely. I completely agree with you.
One thing which I have coming to my mind, Dr. Das, we always treat such patients, ejection fraction 15%, 20%, 25%. We give AICD, we see if there is an indication for CRTD, we'll do CRTD, if otherwise not. A lot of patients, they don't agree for LVAD, because LVAD as such is a good destination therapy, but at the same time it has a higher risk. It's not less than 10% in the best of the centers. And so what do you think? Do you think that these patients should continue on optimized medical therapy, but at the same time we lose them many times, because finally it's a heart failure and you can't do much except for the best of the treatment with the SGLT2 inhibitors, new drugs coming up. I mean, we have to live with it, or we can do something more definitive, or think, or we should we really push for LVAD in most of the patients if they have recurrent heart failure? Because LVAD itself, when you tell them 5 to 10% is the overall risk of the surgical treatment, and we have personally lost few patients, then you repent and you feel that maybe if we had continued with the medical treatment, it would have been better. What do you thought? What is your thought process?
First thing is that you see the recurrent of hospitalizations and also recurrence of heart failure. The most important factors that play in the patients are various etiological or precipitating factors. If they are treated well, definitely the chance of recurrence of the heart failure and chance of recurrent hospitalization will reduce. Having said all this, so far the question of the various device therapies is concerned, definitely the CRT and CRTD, they have changed the scenario, especially after the MEDIT-2 trials and all. They have shown the definite improvement in ejection fraction. Now, some group of cases of CRT and CRTD also fail. In those cases, if they fail, then possibly LVAD is a different good option. But as it is a very, very costly affair in many centers, in your center, definitely the patients are getting the benefit, but in many centers, the facility is not available, or if it is available also, they are not affordable. And that's why the LVAD should be reserved for patients who have really failed with the optimized therapy or with the CRTD therapy. Now, since the cardiac transplantation, which is another destination therapy for heart failure, end-stage heart failure management. Now, here again, the provision for the heart, the transplant heart, or the management for the getting the heart is a difficult phenomenon. Though it is though with the awareness it is coming up, but definitely the acquiring the heart is not easy procedure. That's why the concept of LVAD has actually come up, and LVAD has become a destination therapy. But as you said that there is high chance of infection, high chance of, again, mortality, even with the LVAD, and that's why possibly you'll have to reserve your capacity or the final approach for some more patients really who have failed the therapies with the commoner approaches.
Okay, so I think we have to got the point, and it's recorded. Good round of applause for Dr. Das for coming in and helping our section. and he will continue to do a lot of work for the CSI and for the cardiological fraternity. Thank you very much.
Thank you, Dr. Gupta and whole team of yours.
Thank you. So we move on to the next topic. Dr. R.D. Yadav was available just now. He's not available on phone. He said he will be talking about device, but in the meantime, we will request Dr. Amit Munjal. He missed his in the morning topic to go and present his talk. He's from Hisar, a young interventional cardiologist. Dr. P.K. Pandey and Dr. Shastri, I would like you, being a colleague, stay back for some more time and just stay for Dr. this talk and then Korori talk and then Tavi. We're finishing at 6 p.m. So Dr. Amit Munjal will be speaking about acute coronary syndrome, or you talk about something about heart failure? Huh? Oh yes, the very important topic, approach to chest pain. That's very important and clinically relevant for the physicians, non-physicians, for public.
सर कौन सा है? ये वाला खोल के देखूं सर? अच्छा ठीक है। जी सर। जी सर। कॉपी कर दूं सर? ज़्यादा बेटर रहेगा। अच्छा मुझे ही आगे करना है। नेक्स्ट सर वो है एक स्लाइडर देता हूँ मैं आपको। वो तो चेंजर स्लाइड चेंजर। बाकी सर यहाँ से भी कर सकते हैं। ये सब स्लाइड चेंजर है ये भी। जी ठीक।
Thank you, Vivek sir, for such a kind introduction. I am Dr. Amit Munjal, practicing at